bit different. And so it looks like some people joined and are listed as Clover. So if you just want to rename yourself by kind of hovering over your name in the participant list and then clicking the three little dots and renaming, that would be great so that we know you are here. And feel free to turn on your camera so we can see you as well. And we will get started. So Melissa, you already started the recording. If you want to go to the next slide. So my name is Shamia, or Mia. For those of you that do not know me, I am the Director of Viral Hepatitis Prevention and Clinical Services, and I will be the facilitator for today. Today's agenda will include introductions and announcements, a didactic presentation on drug-drug interactions and considerations for hepatitis C treatment by Dr. Clark Allen, an adult case presentation, and then a Q&A kind of session, and then some quick closing remarks. First, some in-chat introductions, as well as some brief announcements. So before we get started, I would like everyone to take a second to introduce themselves. This will help us get to know who's who as well, in case you are listed as Clover. So please introduce yourself with your name and role and your organization, and whether or not this is your first echo session.
I can go. Hi, everyone. My name is Tamla Clyde. I am an epidemiologist at the Tennessee Department of Health. And this is my, I actually can't remember which echo session this is, but this isn't my first one.
Awesome. Thank you, Tanwa. So we're always happy to have people from our team join as well. This is a little bit different session because we are switching gears a little bit. So we have switched, for those of you that were at the last session will know, we switched our accrediting body over to Southeast Age Education and Training Center. And so here you will see a QR code and the event link for registration. I would think if you are at this meeting, hopefully you've already registered, but if you haven't, now's your opportunity to go ahead and register for this event. So we can put that in the chat as well, the registration link. And yes, it looks like Clover put it in there. It will take just a moment or so to go through kind of the initial registration. And then it's my understanding after that, it's a lot quicker, just kind of add the event. But Clover, I know you're on the call. It looks like now, is there anything I missed or anything you want to add related to kind of this transition for our accreditation and CE?
No, that's pretty much accurate. Like you already noted, if you don't have that initial account, once you get it set up, it's a much smoother process moving forward. Makes it a little bit easier in tracking your CE coming from this one spot. And I would say, you know, you'll also now have access to a lot of other educational resources through the Southeast AIDS Education and Training Center. Not 100% sure what happened with the Zoom link either, but that should be cleared up by the next session too, since we'll be transitioning that over to my actual Zoom link.
Yes, and I said the same thing. So thank you for reiterating that as well. All right, next slide. So please turn your video on and mute yourself unless speaking. Please come off mute, of course, to ask any questions that you may have though. And Anastasia, did you notice that anybody came in via phone?
Yes, there are 3 phone numbers in the chat. And I just also wanted to reiterate, if your name is incorrect, please rename yourself. I will put the instructions in the chat.
Anyone that answered by phone, do you want to come off mute and share who you are and where you're coming from?
So Mia, to add, we've got 2 phone numbers with a 901 area code. The first one ends in 7841. And the other one ends in 8188. Would either of you like to come off mute? Okay, and then we've got a third phone number, area code 786, and it ends in 7545. Would you like to come off mute? Okay, we'll continue to monitor. Thanks, Mia.
Sounds good. So some quick reminders, please never discuss any PHI and please treat everyone with respect. So with that, I'm going to turn it over to Dr. Allen for today's didactic presentation. Dr. Allen, please say next slide when you would like us to advance the slides.
Thank you for the introduction. I want to first start off by saying I don't have any conflicts of interest to disclose with this presentation. I want to make sure we have some objectives to cover during this session. I'm not going to get too far off in pharmacology, but I do want to kind of explain some of the mechanism that will explain some of the reason why these drugs interact with the hepatitis C medications. We also want to know which ones are safe, which ones are not safe, and which ones to be aware of and monitor while treating a person for hepatitis C. And then we also want to make sure that we're following up with all medications if they're starting or stopping throughout therapy as well. So several different things that we want to cover during this session. Next slide. Got a list of abbreviations. There's going to be a lot of charts in this presentation, so a lot of things are abbreviated to not make the slides too busy. So I've got several here. The main three at the top are going to be the drug names themselves. Gocapivir, Preventosvir, trade name Mavyret will be abbreviated as GLE-PIV. And then subsequently, sofosbuvir, velpatasvir, trade name Epclusa, and then ladipasvir, sofosbuvir, trade name Harboni. Those will be at the top of each one of the charts. And then I've got some more abbreviations as well listed below that I'll kind of elaborate on when we get to them. Next slide. We can go on to the next slide. And this will be a drug interaction session today. We want to make sure that even though we've already went through all of the kind of preliminary assessment and kind of treatment options and then also post monitoring, we want to make sure that we are doing this on the front end. It is something that's recommended in the guidelines as part of your pre-assessment prior to starting hepatitis C treatment. And it actually refers you to the hepatitis C interaction checker with the University of Liverpool. So it actually has a link to it in the guidelines itself, which is what we'll be using today as our primary source for all of the drug interactions listed. Next slide. Here are the drug resources that are available. Now, the one on the left is the one that's it's free and available to everyone. It's also documented in the guidelines, but we also have other ones that people may have ability or options to, LexiComp and Micromedics if you have the subscription. So for the purposes of today's presentation, we'll make sure that everything that is being presented is from Hepatitis C drug checker with the University of Liverpool. Next slide. So we'll talk a little bit about mechanisms. It's not going to be too much. I don't want to bore anybody, but I do want to, it does have a significance of why these things matter. So next slide. There are a couple of different mechanisms. The main thing to note is medications are metabolized through several pathways, and that's where drug interactions will occur. If drugs are going through the same pathway, there's a potential for there to be some kind of friction there and can cause issues. So we want to be aware of those. The main one that a lot of drugs are metabolized through is the cytochrome P450. It is kind of just a kind of conglomerate of enzymes that utilize drugs to be metabolized through. There's also P-glycoprotein and organic anion transporting polypeptides. Those are kind of the main ones. There are other kind of pathways that medications are metabolized through that can interact with hepatitis C medications. Those are the main ones. Now, I also want to make sure that we mention there are inducers and inhibitors. So that's how there are interactions that occur. Some medications can cause inhibition that can increase drug concentrations, and then there can also be inducers which actually increase the amount of drug metabolized, how quick it is, and therefore it will actually reduce the concentration. So you can see how there can be an elevation that can be too much of a good thing, can become a bad thing, or too little of the good thing cannot be effective at all. So there are different ways of how drug metabolism can be increased or decreased accordingly, and we'll cover those with subsequent slides. Next slide. We'll keep going. So this is kind of an intro. So here is the main drug interactions that you'll see for most hepatitis C medications. This is pulled from the guidelines. So if you want to look at the hepatitis C guidelines, you'll see the same list. It's a very robust chart, and I've kind of separated all out to make sure it's more kind of palatable and easy to understand. versus a big long chart that kind of takes up several pages. The main two that you will see most patients have on their profile are statins and things for acid suppressants. So that's why I put them at the top. And then subsequently, I put other medications that can also be involved: anticonvulsants, anticoagulants, antiarrhythmics, HIV, TB, and then there's going to be several other medications on the final slide that we'll make sure we cover. There's a lot of things that can interact, but a lot of things are just going to be, you just need to monitor, not necessarily need to avoid. And that's what we want to discuss today. Next slide. So a lot of patients in our adult population, they will be on statins, not so much with the pediatric population. We won't have to worry about that as much. For adults, we see a lot of patients on statins for cholesterol or secondary prevention of a stroke or heart attack. And we want to make sure we're addressing this accordingly. So whenever you see a patient that's on a statin and you're wanting to start hepatitis C treatment, I want you to know what is a good statin and what is one that you probably want to avoid. Now, I want to make sure we educate everybody again on the GLE-PIB. That's glecaprevir, preventosvir, trade name Mavyret. And then we got sofosbuvir, velpatasvir in the middle, trade name Epclusa. And then we got the less often used one because it's not a pan-genotypic agent, the ledipasvir, sofosbuvir, trade name Harvoni. So I want to make sure that I highlighted the first two first. And one of the main drugs that I see in my clinic are atorvastatin and rosuvastatin. So that's usually, as you can see, there's a red marking on trade name Mavyret and atorvastatin. The main reason that that's occurring is there's inhibition of one of the cytochrome P450s. What that's going to do is that's going to not necessarily cause any issue with Mavyret, but it's going to increase the level of the cholesterol agent, the statin, to levels that can cause increased risk of side effects. So it's contraindicated. That's why I put a red box there. So that's why we want to stay away from atorvastatin and glecaprevir, preventosvir, trade name Mavyret. So that's kind of one that's just out. We do know that it's not going to cause any issue with Mavyret. It's just the increased risk of myopathies, myalgias, all those muscle issue side effects with statins are increased to not safe levels. And so that's why they avoid it. With sofosbuvir, velpatasvir, and Harvoni, trade name Harvoni, ledipasvir, sofosbuvir, trade name Harvoni, it's just monitoring. We want to make sure we monitor patients for any muscle pains or complaints while they're on the medicine. Rosuvastatin has similar guidance. It prefers the max dose of 10 milligrams with trade name Mavyret or trade name Epclusa, and then it prefers to not be used in combination with ledipasvir, sofosbuvir, trade name Harvoni. So knowing how to navigate this to make sure we're not putting patients at risk of increased adverse effects is key. So I want you to save this slide if you don't have a resource like this already. If you see a lot of patients on statins and you're wanting to treat hepatitis C, I want you to know how to navigate statins to make sure we're avoiding any adverse effects associated with these medications. As you can see, pravastatin is the only one that is actually A-OK with Epclusa, trade name or generic name sofosbuvir, velpatasvir, and then there's also restrictions of monitoring or dose adjustments with glecaprevir, preventosvir, or ledipasvir, sofosbuvir. There are more options that are contraindicated with Mavyret. That's associated with the protease inhibitor aspect of Mavyret, and so that's why you see more red on the side of that agent versus not so much with the other two agents, the sofosbuvir, velpatasvir, and ledipasvir, sofosbuvir. So lots of things here. I've got a legend at the bottom to kind of explain. Green means good to go. Yellow means there's going to be some type of monitoring, and then a red is probably going to be a no-go. So I want to make sure we fully understand each one of these charts. They're all going to look the same going forward. So, but I wanted to start with statins because that's the most common agent that I see that's going to cause interactions with hepatitis C medications. Next slide. This is the other most common drug class that I see with patients having some type of agent on board, and I need to know how to navigate through that to make sure that we don't have a medication that's started for hepatitis C that's going to cause issues. So with glecaprevir, preventosvir, trade name Mavyret, it looks pretty good as far as antacids, which includes Tums, Rolaids, Alka-Seltzer, Maalox, all of those over-the-counter products. I try to go through all of those agents when I counsel patients to jog their memory because they're not prescription medications. I want to make sure that they're thinking about things that they take over the counter that they wouldn't consider to be medications that can interact with glecaprevir, preventosvir, or any of the other hepatitis C medications. If they're on those medications, the antacids or the H2 blockers, which that's basically just Pepcid or famotidine right now on the market, those are good to go. with glucocaphylpropinavir. There are issues with the other two, and we'll get to those in just a second. I did want to put a star beside the PPI, or it's a proton pump inhibitor. That includes omeprazole, pantoprazole, lansoprazole. All of those PPIs fall into this class. Now, for different drug interaction checkers, they will give different guidance on this. The hepatitis C interactions with the University of Liverpool gave that it wanted to be monitoring of it needed to be 20 milligrams or less of omeprazole. Lexicomp will give you different guidance saying that it's okay. Now, the main thing to know is that what is the interaction that's occurring? The main thing that's occurring is if you go off into the pharmacist perspective to kind of really dig down deep as to what's actually occurring, it's actually not clinically significant of what's observed. It is lowering the AUC, which is the area under curve of the concentration of the drug, but we do want to monitor that accordingly based on the drug interaction. Don't want to get too far off in the weeds, but I did want to explain what's going on there. Usually, if I have a patient that has acid suppressant needs, I'm probably going to be leaning toward glucocaphylpropinavir prevention, trade name Mavorite, for this reason. With the other two agents, separating antacids by 4 hours, it can be complicated with timing. So you just want to take that into account when counseling a patient. If they're using antacids, but they need to use one of those agents, you really need to make sure they understand. As far as the H2 blockers, famotidine specifically, there is a time restriction. They wants to be given at the same time as the hepatitis C medication or 12 hours later. There is some mention that it can be given twice a day. I prefer just once a day, and that's what the language says on the hepatitis C interactions on the University of Liverpool. And then we get to the bottom where usually when I'm going to have a red box, it means it's contraindicated. For sofosbuvir, hepatosvir, trade name Epclusa, there is a contraindication to omeprazole or any of the PPIs with trade name Epclusa, but there is guidance. If you had to use it, you have to administer the medication 4 hours after the Epclusa. The Epclusa has to be given with food, and the omeprazole has to be given 4 hours later. So another timing restriction there, and it has to be given with food. That's not a normal requirement with Epclusa, but for this case, it is a requirement because we're trying to prevent the acid suppressant from causing there to be I guess, an increase in the pH of the stomach before the medication gets absorbed. And that's kind of the main nuance to this. There's no inhibitors, there's no inducers with this. It has to do with the acidic environment of the stomach. It needs to be as low as possible. The pH needs to be low, so it needs to be acidic as possible for the medication to get absorbed. If we're taking things that suppress the acid, that means the pH is going to go up and it's not going to be absorbed as correctly. That's kind of the main thing of why acid suppressants is on this list, is because it's messing with the acidic environment of the stomach, which could therefore mess with the absorption of the medication. So that's kind of why I wanted to stress this one as well, especially for over-the-counter medications. Next slide. Anticonvulsants. As you see, there is a ton of red on this one. These are all inducers of the cytochrome P450, so that means they're going to be increasing the metabolism speed of the hepatitis C medication. So when you see these agents, carbamazepine, phenytoin, they're pretty much going to be a no-go for all hepatitis C medications. We're going to need to switch them to something else that is appropriate and can be tolerated with the hepatitis C medication while we're going to be on treatment. So I did want to make sure I put some options at the bottom. Usually when I have a patient that's on phenytoin, I will need them to see their neurologist, get them switched to something like levetiracetam, trade name Keppra, for the treatment, and then they can switch back, or if they want to stay on Keppra going forward, they can. So those are options. The other option is if you see a patient on oxcarbazepine, trade name Triliptal, Mavorite, glucocaphylpropinavir prevention is going to be the agent of choice. There is some monitoring, but it is been shown to be safe. I've had patients be on oxcarbazepine and trade name Mavorite for the duration and be just fine and get cured. So there is one agent that you can use if they're on oxcarbazepine, but other agents like phenytoin and carbamazepine, it's a no-go. We need to switch them to something else while they're on hepatitis C treatment. The medication for hepatitis C will not work. The inducers are just too far great, and the drug concentrations will just never be enough to cure the hepatitis C. Next slide. So anticoagulants, we'll see a lot of patients on these. Most of them are just going to be monitoring. Everything's yellow. It's not to be, it just means caution. We want to make sure we're monitoring those patients. Their INR can be elevated with warfarin. Their INR can elevate with the other agents as well. The only one that's a no-go, just because there's a increased risk of inhibition and the drug concentration levels will go too high, is with dabigatran, trade name Pradaxa. So looking at this list, everything is mostly safe, but there is used with caution. We want to make sure we're monitoring those patients accordingly, making sure there's not any increased risk of bleeds. Next slide. So I want to have an echo pause to make sure if I have any questions so far. I know I've went through a lot of material. I want to make sure we open it up for questions. This is from my recent trip to Canada. This is in Banff. This is Lake Agnes. This is just north of Lake Louise. So it's about a 2.5-mile hike up to Lake Louise. There's a tea house there. So you can have tea and have biscuits before you either continue your hike on forward, or you can go back to Lake Louise. So any questions right now? And you can put them in the chat or you can come off mute.
So I think it wasn't long ago that there was a question that came up in particular related to some of the anticonvulsant medications. And I know you mentioned that really they should probably follow up with their neurologist and see what else they can take. But I've heard that some patients really, it took them a long time to find the medication that was working well for them. And there could be a lot of hesitancy to switch with medications. I'm sure perhaps that's the case with other ones. It's just, this is the most recent question I recall. So what do you do if they're like, we really don't want to switch their anticonvulsant? So can you just do super close monitoring, or is it just have to rethink that plan?
Based on what I know about the pharmacology of those inducers, they're just very strong CYP inducers, and they're going to increase the drug metabolism to level or what we're not safe with. So we could try to increase the length of the hepatitis C treatment. That would be at the discretion of the insurance company, if you will. But usually if I see those medications, I would probably need to have a conversation with the neurologist and the patient if there is a better alternative. But like I said, phenytoin and carbamazepine, I usually just say it's a no-go and we need to look at another option or try to find another option. I haven't attempted to try to treat someone that's on that agent, just because I know how strong of an inducer those are of those that group of enzymes that is increasing drug metabolism. That would be a conversation for a very specific case that we would just need to talk with, and we could try it. There would definitely be a case report or a case study if somebody was going to try to get treated for hepatitis C even while on those agents. It would definitely be a risk, but it would be something to just talk with everybody and make sure everybody's on the same page before we attempted that.
Really interesting.
I think from a pediatric standpoint, there are two medications that our kids are not usually on a lot of medications. Kind of what you pull out, yes, the anti-epileptic or anticonvulsants, and sometimes we have them on famotidine or PPI. In our case, it's actually easier just to say, we're going to stop the PPI, we're going to kind of do some dietary changes, and kind of choose a different medication, or at least for those 12 weeks, keep you off the medication and see if we can wean you off. Now, with the anti-epileptic medication, it's a little bit more tricky for us because a lot of the time they're on multiple medications, their seizures are hard to control, and that's definitely a conversation you want to have with a neurologist. That's when it becomes more tricky, I think, for a pediatric standpoint as well.
Good question, Mia.
Yeah, I also see a question in the chat. Would you tell patients to avoid taking medication with milk?
For the hepatitis C specifically, Jenny? Yeah, no issues with that. So mainly with the agents for hepatitis C, there's no restriction or no guidance or no requirement for food. Glucaprevir preventative trade name Maverick does prefer food. The other two agents, the sofosbuvir, velpatasvir, and ladipazole sofosbuvir, those do not require food. Taking it with milk will not change anything. There are other medications that do have issues when taken with milk. These do not. Good question. We had not discussed that.
Dr. Allen, this is Laura. So was that, were your list all inclusive, or were they, you said those were just the most common medications for each of those lists?
Pretty all inclusive for what's in the guidelines. I tried to make sure I covered everything that's in the guidelines that is most common. Now, of course, I couldn't put everything that was in the guidelines that was mentioned because it would be too many slides and too many words on the page. I wanted to make sure I was concise as possible, but also hit the high points to make sure these are ones that you're probably going to see in practice. Like, you're probably not going to see all those anticonvulsants, but they were in the guidelines, so I did put those. But if you go and look at the guidelines, there are other agents that are there that I did not list, but there are less common. And I will try to, at the very end, there's a slide that kind of is a catch-all to try to we'll go through that at the end.
Okay. The case we're going to talk about, there is a medication for seizure disorder. So that's what really piqued my interest. And we'll talk about that later then.
Yes. All right, we can go next slide if no other questions. Okay, so now we've got antiarrhythmics. The main one that patients will, or practitioners will see is probably amiodarone and digoxin. When I see a patient that's on amiodarone or digoxin, you're going to be monitoring it. It's an inhibitor. There's a risk of increase in drug concentration, so you want to monitor the level of digoxin. Now with amiodarone, you can see it's got red boxes for both agents of the trade name Epclusa, trade name Harvoni, and then you're kind of just left with glucaprevir preventative trade name Maverick as your only option. So if you see somebody, I'm going to do everything I can to make sure I minimize all other drug interactions to make sure that trade name Maverick is going to be the agent with amiodarone. The risk with amiodarone is if you tried to change it, it's a very long half-life. It's about 72 days half-life. It's going to take forever, and you don't want a patient to be off their antiarrhythmic for that long just to get hepatitis C treatment. So I've only had 2 people that I can think of that have been on amiodarone, and we always go with glucaprevir preventative trade name Maverick with those patients. Next slide. Now we've got a big section for HIV medications. There is a very long list of HIV medications. This is the best I could do to keep it as concise as possible to not be super lengthy. So we'll first focus on the first 2 are tenofovir and tenofovir. There's an old version and a new version, disoprostyl fumarate and alafenamide fumarate. Those are just the 2 agents of different formulations of tenofovir. The newer version doesn't have any interactions. The TAF is the newer version. It does not have any interactions. There is some monitoring associated with sofosbuvir, velpatasvir, and ladipazole sofosbuvir. The next 2 are kind of grouped into the NNRTIs, which is non-nucleotide section of the HIV medications. So doravirine and ripivirine are good to go. No issues there, but it's efavirenz and etravirine that have issues with glucaprevir preventative and sofosbuvir velpatasvir. It's just a no-go with those. Those are not preferred with that option, with those agents. So if you have somebody on one of those agents, probably want to be leaning towards seeing if you could use ladipazole sofosbuvir in that case. Cobicistat is a booster. It's not a specific HIV medication on its own. It only helps another medication for HIV treatment, but you just wanted to make sure, I did want to include it there to make sure you're monitoring if a patient is on a boosted regimen with cobicistat. Protease inhibitors also have another booster called ritonavir. It is also kind of the same restriction as cobicistat. You want to make sure you're monitoring, but if you're going to be starting, or if you want to consider starting glucaprevir preventative, probably want to steer clear of it with a protease inhibitor. The main reason being there's a protease inhibitor in trade name Maverick, and then the protease inhibitor in the HIV regimen. Normally we don't do that. There's a risk of increased drug concentrations, and it's kind of a duplication of therapy because there's 2 different protease inhibitors kind of doing the same thing. We prefer to steer clear of that. We prefer the other options if they have a protease inhibitor in their drug regimen. The integrase inhibitors, the main one on the market is Tivicay or dolutegravir. It's a great one. No issues with any of those agents. There's other integrase inhibitors as well. They're usually in combination pills. Those are A-OK, no issues there. So several agents to be aware of with HIV medications, but most are good to go with most of the hepatitis C medications. Next slide. Then we got TB medications. TB gets a little tricky. I would definitely, if you had a patient who is co-infected with TB and hepatitis C, I would want you to refer them to an infectious disease specialist, because you see at the bottom, one of the, or all of the agents that are involved with RIPE, if you think about the last one being rifampin, rifabutin, or rifapentine, they're a no-go. They're great immense inducers of the cytochrome enzyme. So it's going to be increasing the drug metabolism to a point where those are not going to be effective. There are alternatives, different TB options, treatment options that are on the market now. I didn't want to go into much detail there, just knowing that if you see rifampin, which is probably what you're going to see if they're on TB, or unless they're on a newer option, you're probably going to be a no-go to be treating hepatitis C while they're getting active TB treatment. So that'll be a conversation to have. You probably just need to find out when they're going to finish their TB medications, and then you can consider starting hepatitis C medications after that. It's kind of the main point I wanted to take home here. Next slide. And so here's kind of the final list. I tried to just put as many as I could, and trying to be broad, but also cover all my bases. The main one here is one for oral contraceptives with ethinyl estradiol. So any agent that's going to have, that's a birth control pill that has ethinyl estradiol is not going to be, it's going to be contraindicated with glucocorticoid prevention trade name Mavorite. Other agents are okay, but so if you know somebody who's of childbearing age and they're going to be on something for oral contraceptive, you want to make sure you know what that agent is, because if they're going to be on ethinyl estradiol, you don't need to be choosing Mavorite in those patients' cases. For Bosentan, not going to see that in too many patients. It is for pulmonary hypertension. It is not indicated for use in trade name Mavorite or trade name Epclusa. Cyclosporin, there's a little monitoring with the glucocorticoid prevention. St. John's wort, if you've ever been to a drug talk with drug interactions, you're going to see St. John's wort is just a no-go with many things. I don't know who takes it, but it's always in there, so I want to make sure I mention as well. And then I wanted to kind of separate out, I know I couldn't cover all medication drug interactions. So cancer medications, there are a ton. I couldn't list them all here. So if you've got a patient that's on any type of cancer treatment, either it be oral options or chemo infusions, just make sure you get on the hepatitis C interaction checker and look at it to see what is if there's any interactions there before you start. And then of course, ask questions if you need to. Diabetes medications, really didn't see any medications. So I think everything's good to go for patients who are with diabetes, as far as there's no any drug interactions there with hepatitis C medications. There are some hypertension medications out there, not as common, but there are some out there. So if you're kind of off the beaten path of hypertensive medications, just go ahead and do a quick check to make sure there's not any monitoring. I didn't see any outside of aliskiren that was contraindicated. So that was kind of the main one. So just definitely monitor, definitely do a drug check just to make sure. Mental health medications, there's a lot of those out there. There are some that are not, need to be monitored, and some that are contraindicated. Just do a drug check on that. This presentation could go on forever if I put all that in there. So I just wanted to kind of make sure I put a plug for those, to make sure you're looking at those. If anybody is taking any of those medications for mental health or cancer, making sure we're doing a drug check just to make sure that there's no interactions with those medications. Next slide. So follow up. If you're not sure how to handle a drug interaction, kind of like what Mia said, if there's kind of a tough spot where we don't really want to change, just reach out. I've got an email here. You can reach out to me and shoot me a question just to see what is safe and what's preferred, or what my recommendation would be. Feel free to ask me. Want to make sure we're always following up with the patient while they're on medication to make sure they haven't started anything new once they started the Hep C medication. Every now and then, patients will tell me, oh yeah, I started such and such, and everything's okay, no drug interaction, but I do appreciate them telling me that they did start something new. That way I'm monitoring that. We don't have to do anything to shift gears while they're on hepatitis C treatment. So make sure you're following up with new or discontinued medications, making sure you're aware of that, and just try to be a patient advocate for them. My patients who I talk to them at least once a month, if not more, depending on how much they want to ask me questions. But they really have, I build a relationship with my patients, and they really feel like they can come to me and ask me questions, and they're very candid about what's happening in their life. So I'm very engaged in their life for these 6 months or so, however long I'm with them, until I get them treated and cured. And then they're very blessed and thankful when it's all over with, and they're very appreciative of all the work I've done. So being engaged with your patient population is important. Letting them know that you care just as much as they do about getting cured.
Awesome. Thank you, Dr. Allen. So much information. I see a few questions in the chat. Go ahead.
Yeah, I'm reading them right now. Yeah, you can go ahead and read them out, Mia.
Okay. So we'll start at the bottom. What about MAT prescriptions? Are those safe to take with all the hepatitis C treatments?
You might have to tell me what MAT stands for. I'm not.
Oh, medication assisted treatment, or same as the MOUD. So like different options. I guess the U would be one. Does that help? Substance use disorder medication. So medication, opioid, yes, use disorder treatment. Sorry. I should be more specific. That's on me.
I didn't see anything that I can pull up the guidelines real quick behind me. I didn't see anything that kind of there was any like restrictions to those. There might be some monitoring associated with it, not anything that was contraindicated. I would have included that. I didn't think there was any issues with any of the opioid medications either. So I don't think so, but good question. That would be one that, yeah, since I didn't cover it specifically, I would just do a drug check. But based on looking at the guidelines and looking at all the medications, I did drug interactions through the hepatitis C interactions checker with the University of Liverpool. Didn't see any, but can't rule it out. There's going to be new medications that come on the market. So always do a check just to make sure. Good question.
Clinically, this is a question that comes up quite often, particularly in clinics where we care for people with opioid use disorder and other conditions. Buprenorphine, naloxone, naltrexone, any of those in combinations or standalone agents do not have interactions with any of our first-line hepatitis C agents. The one medication that does give me some pause is methadone. Methadone does have an interaction with glycapropobrentisvir, specifically with the protease inhibitor, and that can boost the levels of exposure to methadone. And so any plan to treat with a glycapropobrentisvir-based regimen along with methadone will require additional monitoring because the methadone exposure may be increased because of the inhibitor effect of the protease inhibitor. Ultimately, the hepatitis C treatments, though, will not be a major impact on buprenorphine, naloxone, or naltrexone, which actually plays into, I think, the next chat box question as far as the dosage of buprenorphine. Dosage of buprenorphine, whether it be for opioid disorder or secondary impact on pain management or other aspects, shouldn't be impacted by hepatitis C treatment. But again, methadone may be.
Thank you. Great questions about MOUD. That does come up frequently. Let's see. It looks like Dr. Talley also had a question. Are conjugated estrogens for menopause contraindicated with Mavorite, like estradiol containing oral contraceptives?
I might have to look that one up. I'm not sure. I want to say yes, but I don't want to say it without being confident. I want to say yes, that there might be an issue. So let me take a look at that real quick and see what I can find.
Sounds great. And we can circle back to it. So lots of great questions regarding and comments regarding drug-drug interactions. Any other questions or comments about these? I can tell you, I would be reaching out to a pharmacist, would be my comment. But I do think that this is a great topic and lots of things to discuss. And really, a good reminder to be checking. I love that Dr. Allen brought up not just medications, but also the supplements. It's amazing to me the number of patients that I speak to that when you start really talking to them, they're like, oh yeah, I didn't think to talk about any of those. And then they start listing all these supplements that they're taking, you know, for different reasons. And St. John's wort being one that does come up a lot of people taking it for, you know, mood and things like that, different reasons. So really interesting to me that we can't forget to include the supplements and vitamins and herbs and such. So I guess that's a good question. Are supplements and herbs and things like that going to be listed in the Liverpool checker?
I don't think so. And that's usually when I get a question about a patient who takes several herbals. I try to look at other options or see if there's any literature out there. It may not be something that's published, but you may have to look a little further just to make sure. Most herbals, I don't imagine will be any issue, but I always want to make sure that I get a full history because some patients do take several supplements over the counter like that. And I do want to make sure I know about them and I can do a check because some of them I've never heard of and I need to learn myself. So I do have to do some research sometime in those cases of looking them up because there is there's a lot of them out there. So I need to look them up as well because it's not things that I normally see on a day-to-day basis.
Yeah, always interesting.
Well, I got going back to Dr. Talley's question, I did a quick check on the drug interaction with the University of Liverpool. It does not say there's interaction present with gacapavir, pefrensis, trade name Maverick. So it sounds like the conjugated estrogens are good to go.
Super helpful. So in the interest of time, we'll go ahead and start our case presentation, which Laura